everyone. It's been a long time we haven't been working together. So today I make it essentially presentation with incomplete spinal cord injury. Okay, here you go. We know it's incomplete spinal cord injury when it's only partially served the cord, allowing some signals to pass through the levels of injury. This means the patient may still retain some functions and feeling below the site of injury. Necrosis is most common in vehicle incident, others are fault, violence, sport injury, and medical incident and pathology. The location of a spinal cord injury have an enormous impact on severity of the symptom. The higher up on the spine an injury is, the more limitation it will impose. We diagnosed ISCI via symptoms and imaging study. Compared to complete spinal cord injury, the ISCI patient tend to have a better overall prognosis and is able to recover faster. According to American Spinal Injury Association, it defined complete spinal cord injury is the absence of sensory and motor function is in the lowest sacral segment. Otherwise, the incomplete spinal cord injury is the preservation of sensory or motor functions below the levels of injury, including the lowest sacral segment. So we differentiate them with the sacral sparing. What it is either the voluntary anal contractions or palpable or visible muscle contraction below the injury level, or the presence of perianal sensation. So Frankel classified the spinal cord injury into 5 classes, and Class A is totally loss of sensory and motor functions. Class B, the sensory preserved but there are no motor functions. The Class C, some motor functions preserved but there is not useful, and Class D, some useful motor functions retained. Class D, the functions are normal. Modified from Frankel classification, ASIA impairment scale have add some detailed information and still keep 5 grade. 5 class. Class A is complete spinal cord injury, no sensory or motor function preserved in sacral segments at 4 to at 5. Class B is incomplete spinal cord injury. There's sensory but there are no motor functions is preserved below the neurologic level and extend through sacral segment at 4 to at 5. Class C and Class D same also are incomplete spinal cord injury. And Class C, the motor function is preserved. Most key muscle below the neurologic level have muscle grade less than 3, and it is greater or equal to 3 in Class D, and Class E its functions are normal. Now I'm gonna remind you about the anatomy of the spinal cord. So spinal cord itself is organized into a series of tracts or neural pathway that carry motor or descending tract. Sometimes we call it afferent tract, and the sensory or ascending tract. They carry the afferent information. So the descending tract I'm going to talk about is the cortical tract. The ascending tract, the one you got to focus on the dorsal column, the spinal tract, and beside them there is spinal cerebellum tract. Dorsal column. The dorsal column, they transmit the conscious sensation, include fine touch, proprioception, and vibration. This tract is include Buddhist tract and the Gond tract. The Buddhist tract carry information about T6 level, and Gond tract carry information below T6 level. I mean lower trunk and legs. The gun track is the bundle track is more later compared to the gun track. About the spinal thalamic tract, it carries the pain, the temperature, and the light touch sensation. The later spinal thalamic tract usually decussate with three segments of origin at the ascent. In the spinal cord, there's a tract named lissor. This is where the information go up 1 to 2 segment or go down 1 to 2 segment. Wait. The another important information is the autonomic function. They travel within the anterior intermedial tract. The sympathetic nerve system fibers is the spinal cord between C7 to L1, whereas the parasympathetic pathway is between H2 to H4. Therefore, progressively higher spinal cord lessens cause increasing decrease on autonomic dysfunction. The spinal cord is supplied by three vessels, two posterior spinal artery and one anterior spinal artery. Anterior spinal artery supply 2/3 of the spinal cord, and injury to vessel result in paralysis, other pain, temperature sensation, light touch, and autonomic dysfunction. This symptom called the ASA syndrome, the anterior spinal artery syndrome. The posterior spinal artery primarily supply the dorsal column, so injury to the two vessels lead to damage of the dorsal column. Now, how does transformation work, and what is its pathway? Let's find out. First is I'm going to talk about spinal thalamic tract. This one is easy. The information jump into the dorsal granule via the dorsal nerve root. Then is crossed over to the anterior wine. Wait, can you guys see my arrow? The mouse?
Yes.
Okay. The information cross over to the anterior Y commissure, and then goes up to the brain. In this way, going to the brain, it has to pass to the reticular formation. This one is funny because it plays a role in alert the cortex with information. For example, 85% of C fiber, the C fiber is like a neuron that is not myelinated and carry information of achy pain, dull pain, which result from inflammation. And when this information comes here, the reticular formation, it tells the cortex that hey, this body is in pain. You got to do something. But when you are asleep, the reticular shut down. So if someone touch you, or you are having a dull pain, you cannot feel that touch or that pain at all. Then it keeps going to the thalamus, and is the somatosensory cortex. And in here, the information integrated. So now we move on to the dorsal column. The dorsal column decussates in the spinal cord the same as the spinal thalamic tract. No, it's not. Is the information also jump into the dorsal gray matter, and then it's go to the medulla. These tracks do not cross over until they reach the medulla. Here, here. When they come to medulla, it cross over to the opposite side, and it's come to the contralateral thalamus, and also end in the respectively cortex. Okay, now move on to the descending tract. The descending tract. In the descending tract there are two categories into which the descending tract of the nerve system can be organized, called pyramidal and extrapyramidal. Here, pyramidal tract is the red area. The pyramidal tract is responsible for the volunteer of musculature movement. The extrapyramidal tracts are responsible for the involuntary and automatic control of all musculature, including muscle tone, balance, posture, and locomotion, like combined movement. The cell body of upper motor neurons are found in either cerebral cortex, include precentral gyrus, or we call this primary motor cortex, the premotor cortex, the supplemental motor area, primary somatosensory cortex, and prefrontal cortex. And cell body also found in the brainstem, with the axon remaining in the central nerve system. The pathway of the pyramidal tract from the cortex, the axon of motor neuron are collectively referred to as the cell bed. This cell bed are the neurons that highly myelinated and pass through the internal capsule and then the medulla. In the medulla, the majority, about 80% of the cortical spinal tract decussate just after the pyramids and descend from here. Here, the tract called the lateral cortical spinal tract. Here, the lateral cortical spinal tract. The lateral cortical spinal tract go down and synapse with the motor neuron located in the ventral horn of gray matter in spinal cord. From here, it interfaces the musculature of distal lamb, which means fine and precise movement, and the other 20% of pyramidal tract do not cross at the medulla. And we name it as the anterior cortical spinal tract. Here, it's ending here. This tract goes straight down to the anterior wide column, and here is crossed over. From here is crossed over to the upper side, the anterior grayon, and stimulates the isomusculature movements, like very large movement. Next is the extrapyramidal tract. This tract 1, 2, 3, 4. This tract do not pass through the pyramid of the medulla and are involved in the maintenance of posture, meaning involve musculature of the trunk, as well as cue volunteers movement. This tract named as where they began, including rubral tract, reticulospinal tract, olivospinal tract, vestibulospinal tract, and the tactile spinal tract that will not show in this picture. The rubral spinal tract that had origin in middle brain is innervate the muscle of the opposing side of the body because the Q cells as they emerge from the red nucleus in the midbrain and they descend to the spinal cord. It is thought to play a role in fine motor control of hands, but the scientists are not sure about it yet. The reticulospinal tract is originated in brainstem. Is responsible for facilitation of voluntary movements and play a part in increasing muscle tone. The vestibulospinal tract is originated in medulla and it controls the balance and posture by innervating the anti-gravity muscle. The lateral vestibulospinal tract is responsible for muscle tone in the postural muscle. The medial vestibulospinal tract innervates cervical and upper thoracic spine, stabilize the head with regard to body position. The tactile spinal tract originates in quadrigeminal body. The nerve of this tract terminates at the cervical level, allow it to solely coordinate head movement in response to visual stimulate. Thus, beside the dorsal column and the spinothalamic tract, there is spinocerebellar tract I have mentioned before, and they transmit the unconscious sensation. Now we have to remember on the pathway and the anatomy of the spinal cord that every area effect in this pathway of the spinal cord will regard to the respective syndrome. The spinal cord syndrome includes the anterior cord syndrome, posterior cord syndrome, central cord syndrome, and broad sequard syndrome. The anterior cord syndrome is damage to the anterior 2-3 of the spinal cord, and is usually result from the reducing blood flow to the anterior spinal artery. And we usually see this syndrome in the flexion injury. The posterior cord syndrome is rare. It is the injury of the posterior spinal cord, which affecting the posterior column. The central cord syndrome is an injury to the central region of the spinal cord, and that is result from the hyperextension mechanism. The broad syndrome is the hemisection of the spinal cord. It is usually result from penetrating trauma. This red area is responsible for the syndrome. Central, anterior, and prosequat, and in the side, half side of the cord. And the dorsal cord syndrome, posterior cord syndrome. Now we go to the detail. The anterior cord syndrome, if it happens less than 1 hour, it's called the acute syndrome. The patient may feel a back or chest pain of the spinal shock when it is a completely spinal cord injury, and if it happened after days or weeks, it's delayed. The patient will continue to be will have the dysfunction of sensory and autonomic system. The patient will suffer from upper motor dysfunction like spastic paralysis or quadrine paralysis below the levels of the lesion due to damage to the corticospinal tract. Lower motor neuron deficit is also found. It is flaccid paralysis at the level of lesion due to the damage to the anterior arm. And we can find the reflexia in the patient with the syndrome. In the posterior cord syndrome, the patient will have a bilateral loss of vibration, fine touch, and proprioceptive sensation below the lesion. But the motor pain and light are preserved because the spinal thalamic tract and the cortical spinal tract is still fine. The central cord syndrome is usually involve a cervical lesion. The patient will have bilateral motor paralysis, and it is know that the upper limb is more related in the lower extremity, and distally limb is more extended than the proximally limb. Some patient will have the dysesthesia is a burning pain in the arm, or is a burning pain sensation in the arm, and loss of pain, temperature in the arms also found. In Broad-Sequard syndrome, in the ipsilateral side injury, the patient will lose of all sensation at the level of the lesion. Patient also loss of proprioception, vibration, and tactile discrimination below the level of the lesion due to interrupted postural column. The segmental flaccid parasite at the level of lesion due to affection of the lower motor neuron. Spastic paralysis below the level of the lesion. Ipsilateral Babinski sign due to the affections of upper motor neuron action in the lateral cortical spinal tract. In lesion about T1, Honor syndrome occurs due to damage to ipsilateral sympathetic fiber. And in the contralateral side, the patient has a loss of pain, temperature, and non-discriminative touch sensation, 1 or 2 levels below lesion due to an interrupted spinal thalamic tract. I have to go back to here because I forget to tell.
Tell us.
Information, important information. I forget this because the spinal thalamic tract cross over in the spinal cord. So the damage in the spine in the spinal cord exactly will lead the symptom of the contralateral side of the body, and the dorsal column crossed over decussate in the medulla. So the injury in the spinal cord will lead to symptom of the ipsilateral sign. This is I just want to mention it's not really important. So the injury in the cervical spine is the most limiting and immediately life-threatening. That can cause paralysis or weakness or loss of sensation of all four limbs. The C1 to C5 injury may lose ability to breathe without assistance, and the central cord syndrome are easily found in this area. Injury of the thoracic spinal cord will generally leave the survivor with control over their arm. The lumbar and the pelvic, well, you know that the spinal cord itself ends in level of L1 and L2, so the injury of these below the L2 is not considered as a spinal cord injury. But injury to this area will cause caudal equina syndrome, coronary medullary syndrome, with weakness in hip, leg, thigh, buttock, and a problem in bowel control. Now, the clinical presentation. The initial clinical evaluation of the patient with suspected spinal cord injury begin with a primary survey. We focus on life-threatening conditions. ABC's assessment take precedence. A spinal cord injury must be considered concurrently. Performs careful history taking focus on symptoms related to vertebral column, ascertaining the mechanism of injury to identify the potential for spinal injury. The exoskeleton should be examined completely to identify and provide initial treatment of the potential unstable spinal fracture. So we need to classify spinal cord injury via the test of motor function, sensation, reflexive, perianal evaluation with ISIA classification system. Beyond the sacrospinal knot, the spinal shock, spinal shock, neurologic deficits will determine the level of injury. I have some note in here. The indication of the presence of the sacral fiber is of the significance in defining the completeness of the injury and potential for some motor recovery. These findings tend to be repeated and better defined after the period of spinal shock. The presence of neurologic deficits that indicate multi-level involvement suggest spinal cord injury rather than nerve root injury. However, differentiating a nerve root injury from spinal cord injury can be difficult. And in the absence of spinal shock, motor weakness with intact reflexes indicates spinal cord injury, whereas motor weakness with absent reflexes indicates a nerve root lesion. In all patients with spinal cord injury and hypotension and who have hypertension, a diligent search for source of hemorrhage must be made before hypotension is attributed to neurogenic shock. In acute spinal cord injury, shock may be hemorrhagic, neurogenic, or both. Distinguish hemorrhagic shock from neurogenic shock. I have some information for the hemorrhagic shock. It only occurs in a spinal cord injury at or below the T6 level. The hypotension with spinal fracture alone or without any neurologic deficit or apparent spinal cord injury, such as is a hemorrhagic shock. And for the neurogenic shock, it occurs only in the presence of the spinal cord injury above T6 level. The patient with spinal cord injury above T6 may not have the classical finding associated with hemorrhage, like tachycardia, peripheral vasoconstriction due to autonomic dysfunction. If vital signs are confused in acute spinal cord injury and present a high incidence of associated injuries requires a diligent search for occurring source of hemorrhage. To the workup. If the patient comes to us and we suspected spinal cord injury, we need to do some lab tests like arterial blood gas measurement. This to evaluate adequacy of oxygenation and ventilation. We do the lactate. We test for the lactate level, hemoglobin, and hematocrit level to monitor the perfusion status and to detect or monitor source of blood loss. The urine analysis performed to detect any associated with genitourinary injury. Well, the imaging study is always include spinal radiography, spinal CT scan, and spinal MRI. The radio are only as good as the first and the last vertebrae seen. However, it is insensitive to small fracture or soft tissue damage. The cervical spine radiograph must include C7 to T1 junction and recommended 3 standard view performed to elevate accordingly include anterior, posterior, lateral, and orthotic view. CT scan is reserved for delineating bony abnormality or fracture. It is more sensitive than X-ray. Perform CT scan in the following situation: when plain radiograph is inadequate or fails to visualize segment of the exoskeleton. The CT scan of the head is usually simpler and faster to obtain a CT of the cervical spine. At the same time, CT image of thoracic or lumbar spine is easier and faster to obtain than plain radiograph. To provide CT scan is to provide further evaluation when radiograph depicts suspicious and or indeterminate abnormality. When radiograph depicts fracture or displacement, CT scan provide better visualization of extent and displacement of the fracture. The MRI is the best for suspected spinal cord lesion, ligament injury, or other soft tissue injury or pathology. MRI used to evaluate non-unconscious lesion. For example, we can see that the fracture of the body vertebra and it leads to a narrow of the spinal cord. I will not talk much about the treatment management because we have discussed it in the presentation before.
Yes.
But here there's two main information. Here is the methyl prednisolone succinate is proved to improve prognosis in acute spinal cord injury, and when do surgery treatment is for the purpose of decompression and stabilization. Yep, I have the case study for you guys. A 78 years old woman is seen in the emergency department after a fall. She had a significant bruise on her forehead and complained of mild neck pain. Which of the following is not associated with the spinal cord injury most commonly seen in this presentation? Oh. Here is the patient MRI. You can see that the patient have the 1, 2, 3, 4 positions that show the compression to the spinal cord. And okay, the patient is presented with a hyperextension mechanism of injury to the neck with underlying cervical stenosis, which typically lead to central cord syndrome. So this dysplasia in the lower extremities are not characteristics of this central cord syndrome. So A is associated. B, motor weakness more pronounced in upper limb than lower limb. It is true. It is, I have mentioned before in the table. Dysesthesia in the lower extremity is not associated with the spinal cord injury in the central cord syndrome.
Mm.
It is not associated.
Yes,
So
not associated.
the
Yeah.
answer is C. The motor weakness more pronounced in hand than arm is 2, and the selective injury to lateral cortex spinal tract is of the lateral spinal tract leads to the typical pattern of motor deficit, with upper extremity involve more than lower extremity, and hands involve more than arm. Many patients also have burning sensation in the arms in a non-dermatomal distribution. And another information is the management is still controversial, but more recent evidence suggests that benefit with early decompression of the patient. Yeah, that's all information. Some information I want to update. Thank you for your listen.
Okay, thank you very much for your presentation and very good. Especially the anatomy and explain very clearly with the why the patient have problem and the thalamus, spinal tract, or the cortex thalamus or something. So very good. And something is the incomplete spinal cord injury a lot with me, and I try to remember everything when you show for me the image, and maybe I see again and something either a lot of trust, either thalamus trust or the spinal trust or cortex trust. So a lot of things you must remember, and maybe one again I want to see. So you can share a slide for this in the group. And
Okay.
I have some the recommend for you, and I want to the member in my club remember for me is you must different from incomplete spinal cord injury and complete spinal cord injury. Yeah, because very important for you when you approach the patient. And the second thing is the spinal cord. You can show with spinal cord by Franco classification or Asia impairment score. And two things. And this is the spinal cord syndrome. You remember anterior or posterior or the central canal, central cord or the pronos and PROWN. I remember this. So you check again. And 3, 4, 14. You remember spinal cord syndrome, anterior or posterior or central or the frontal wall. And of course, you remember it. You want to differentiation. You must remember anatomy. So very hard because it depends on the anatomy when you want to diagnose exactly the symptom. Maybe the latus or the deep, or maybe the temporal or something, motor, everything. Okay, and you must remember is the anatomy, the spinal is special. Yeah, is special. The trust, the thalamus trust, or something. And you remember is the ascending and descending. Descending you when have the stimulation and into and up to the brain throughout the spinal cord, throughout the medulla, midbrain cortex, and when the stimulation go to the brain and has some the regulation and descending by maybe a motor nerve cell and upper or lower. So maybe I want to see again and try to remember. So
Okay.
very confused now. I
Yeah.
I find some information this, but maybe confused. So exactly the first slide you talking about is very confused and scared and nervous, and so maybe nervous with everybody in here. Because lots of information you must remember.